Good morning, everyone. Salamat for inviting me to be with you, especially since we consider you very great partners in the advocacy for sexual and reproductive health. My topic for today is gender and rights in the management of sexually transmitted infection. Exactly. How does gender affect STIs? And what can we do to improve gender equality and respect for rights in STI management? Let's start with a definition of gender. Gender refers to roles, behaviors, activities, attributes, and relations between men and women that are dictated or prescribed by society. And these are socially constructed or learned from the home, from schools, from religious teachings, from other customs and traditions, for example, even in the law, in media. Gender stereotypes learned are, for example, that women are good for cooking and taking care of children, while men are really good at working, and that men are also prone to aggression and that they cannot control their anger. Polar definitions of men and women that we know do not conform to reality. Gender is different from biological sex. As this illustration shows, sex is biological, referring to chromosomes, genitalia, hormones of both men and women. But gender is culturally defined. So as we mentioned, they refer to roles and responsibilities. They're based on attributes or characteristics, so that women are commonly referred to as fragile and emotional, while men are supposed to be risk takers and aggressive. And from these flow the privileges that are entitled to men in society, so that women are usually financially dependent, even in terms of healthcare, while men are financially autonomous most of the time because they're the ones who are mainly employed or work in the labor force. Gender differences describe not just differences, but because of the entitlements also define the status of men and women, and usually define the inferior status or the inequality in gender. For STI, you're probably more familiar with the biological vulnerability. In women, you have the thin and moist vaginal lining, which predisposes to easier infection and faster penetration of microbes. Because of the interior location of women's genitals, women are less likely to have or to see symptoms. And women will have greater or broader long-term impact and complications from STIs, such as infertility, cancer, and fetal complications. The following epidemiological study shows STIs that have more odds of being transmitted to women with one-time heterosexual contact and if one person is positive, which are all here in this picture. You have more women getting STIs more frequently and in a faster way. I will now go into 3 studies of the prevalence of STIs in women. The first one is in India, which shows that STI is higher among married women, specifically trichomonas, gonorrhea, chlamydia, herpes, and syphilis. And this has been related to gender norms in sexual behavior. So that you had spouses, especially men with multiple partners, and having casual sex, and men resisting condoms. So that's men's characteristics. And on the other hand, you have women who are unable to negotiate for safer sex, and women who are not able to report symptoms. In a second study in Lagos, Nigeria, 2011, also urban center, the reporting of STI there in men and women showed that women reported more than men, young women more than young men, women with primary education more than men without education. So primary education did not protect women. And then Muslim women reporting more than Catholic women. In terms of protective behavior, there's only one. Women reported using condom more than men. But we'll see later on what this means. No? But in terms of protective behavior, men were informing their sexual partners of STI more than women. Men were seeking medical treatment more than women. And men were able to abstain from sex if they had STI. So it seems like they had more control. And these are accounts of stigma and violence. One woman says, "There is no way I can inform him about the STIs and ask him to use condom to prevent him from contracting it. My husband will beat me, even if he would not use condom for preventing the next pregnancy." So no condom even for pregnancy prevention. "If I insisted, he will not give us money for food." And this first-person account is supported or validated by a third woman account describing the same thing, that majority of the women are dependent on their husband. They cannot say no. They can be denied money or other benefits. And that it is only those women who have good business or jobs who can say no to sex when their husbands are infected. So there is not just a gender difference, but also class difference. And we will describe this later on as the intersectionality of gender with other social inequalities. This third study in Uganda actually mentions that sexual empowerment did not protect women from STIs, also among women who were married. Sexual empowerment was defined by this study as, number one, a woman who can say no if she does not want to have sex, a woman who can ask a partner to use a condom, a woman who is justified to refuse sex if the spouse has been unfaithful. So these are women's declarations. And apparently from the study, these declarations were not associated with lower reports of STI. So 28% of women continued to report STIs. And the reports of these women were actually associated also with sexual violence, or the reports of controlling partners and partners who had more than one life partner. The women who showed lesser STIs were women who participated in decision making. So no declaration, but participation in antenatal care, participation in family planning, and other uptake of health services. So apparently it was their participation that insulated them from sexually transmitted infection. The three studies in India, Uganda, and Nigeria actually showed the following gendered patterns of STI transmission. First, a shift to heterosexual transmission, meaning more women were getting infected. And of course, they had more serious complications. And the greatest risk was coming from their spouses. And traditional masculinity and femininity norms predisposed them to sexual risks. Stigma on sex and sexuality, the inability to talk about health rationally, inhibited people from getting to know more about STIs and from protecting themselves. And here we see the layers of inequality that affect women the most. So there's biological susceptibility. On top of that is gender inequality. And then you have other social inequalities like poverty, like the lack of education, maybe cultural biases against them. So it's triple layered inequality that actually predisposes women more to ill health. So this is just to reiterate that in STI, when we talk about gender, we talk about sexual norms and behaviors in men that include the belief that men have sexual license, they need to show their virility, there is a value for sexual conquest, double standard of morality that allow infidelity, multiple partners, propensity for transactional sex, and preference for unsafe and protected sex. The other masculine factor is their controlling behavior, including the propensity for violence. And the last one, which is also a predilection among men, is the associated behavior of alcohol and sometimes drug use. With women, on the other hand, the predominant sexual norms and behaviors are to adhere more traditionally to sexual roles, that sex is a marital duty. They trust their partners to be faithful, and they cannot negotiate for safe sex. The WHO has a study that says because of the predilection for romantic love in young women, here they say sex for young women must be linked to romance, and they are expected to be swept off their feet into sexual intercourse in a way that is not logical, planned, or rational. So how can they protect themselves? Men, on the other hand, may scheme and plot to obtain sexual conquest. So these complementary masculine and feminine norms actually combine to predispose women to STIs. This talk does not include a discussion about STI, HIV risks in LGBT. That's really not my line. Although, yes, we have men, women, and other gender identities that should be covered, for example, when we talk about gender. And what I can only share is that, and you probably know this better than I do, is that gay men are at a higher risk of STI and HIV, and that transgender individuals have a higher prevalence of HIV, STI. Gender inequalities is associated with STIs. Actually, it's directly correlated with STIs. And gender-based violence is the most egregious form. Intimate partner violence, usually sexual coercion, abuse, and violence, can both be a cause, but it also can be an effect of STIs. And gender inequality is not just confined to sexual behaviors, but it also is reflected in economic and educational inequalities. So you have gender inequality and social inequalities magnifying each other, so that to reduce gender inequality would require changes not only in individual and community and family behaviors, but also addressing social and structural problems through policies and strategies. So if gender inequality is a problem, what does gender responsiveness mean? We go to the definition by UNDP, which says that outcomes that actually address gender inequalities, but which also make an effort, or meaning these are processes that encourage equal participation and equal and fair distribution of benefits, that is being gender responsive. And gender responsiveness in outcomes and processes is accomplished more formally through gender analysis, meaning understanding exactly what the dynamics of the inequality is, whether in terms of norms and stereotypes and relationships, etc. And inclusiveness is making sure that when you understand exactly what's causing the inequality, then you take efforts concretely to narrow the gap or to correct or eliminate the inequality. So gender inclusiveness and gender analysis is the route towards gender responsiveness. So how do we improve gender responsiveness? And the first thing we can do is look at the practical recommendations from the 3 studies, which say that making STI screening available and accessible, especially at the community level, is important to detect silent infections in women. And then they also mention addressing negative and masculine norms, also called toxic masculinities, and also changing risk-taking behaviors in men, including marital infidelity. And on the other hand, among women, encouraging women to take care of themselves, to own their decisions, to take charge of their health. And last is to promote or develop better communication about sex, demolishing the stigma, the inability to tell partners what they really feel about sex between men and women in general, but especially men and women who are in intimate relationships. So these are the practical suggestions. Lancet, in their 2021 article, mentioned actually 4 strategies for mitigating stigma in facilities and programs. So number 1 of these is being person-centered, attending to a specific maybe gender characteristics, stereotypes, behavior, relationships that are very individual. The second one is sex positivity, very important. Sex positivity basically means an attitude that accepts that sex is good. It's not bad. It's not shameful. It's not something to make one guilt. It is healthy. It is actually part of sexual health, and that it is natural. It's from the time a baby is born until a person dies. Sex and sexuality are part of the human condition. So this is being sex positive, while the other is being sex negative. And the other is the anticipation of sexual assault or sexual coercion in intimate relationships, and to be able to be trained to provide care, specifically emergency care. So if there is sexual assault in the first days, we should be able to provide emergency contraceptive care. We should be able to provide prophylaxis for STIs, a range of STIs, including PEP for HIV. And then the last suggestion from Lancet is that we enjoin community involvement, community participation in STI care, because they need to be involved. The more knowledgeable they are, the more proactive they are in safe and safer sex, the more the risk of STIs will come down. In 2009, the WHO, in a toolkit, recommended an ethical and rights-based approach for STIs and HIV. And this includes the following principles. Number one is respect for patients for their equal dignity. A second principle is informed consent, so that they know exactly what they have and what's going to be done for them. The third very important point is respect for confidentiality and privacy, critical in places where STIs are heavily stigmatized. A related concept is safety, and this is important also because in many cases, STIs are the result of violence. And if they're not careful in our manner of handling them, we could expose them to danger. So patient safety is critical. And the last point, which has something to do with our approach to the marginalized or those who are treated very unequally, is inclusiveness. So this pertains to women, young people, LGBT, women with disability, women and men with disability, indigenous groups, etc. So people on the fringes, they have as much right as everybody else, and actually require affirmative action to be included in our spectrum of services. And the WHO actually also proposed a comprehensive approach to STIs and HIV, which include the following strategies. So these are strategies from the health system to the individual and community and at the structural level. So the first one is gender analysis, making sure that we understand what the causes of the problems are. Number two is making access to STI services, including the much needed STI tests and treatments available, especially to the most marginalized. And access would also mean training our staff, our providers, so that they know how to do gender responsive care, that they know the rights of patients and they are respectful of these rights, and that they also know how to handle sexual abuse, which includes emergency management, for example, of possible pregnancy, possible STI, possible HIV, meaning prophylactic treatment. The other recommendations pertain to combating gender inequalities by engaging men and checking their harmful gender norms, mobilizing communities so that they understand and they are actively involved in the interventions and in counteracting STI and their gendered causes. And the final point is at the structural level, at the national level, is advocating for laws on gender equality and women's rights, which would redound to lesser STIs and greater sexual and reproductive health for everyone. So this is just a cute picture of how to detoxify toxic masculinity by subjecting it to this is social transformation of norms, so that the end product is equality and inclusiveness. Okay. And I will end with this most recent exhortation to gender equality by none other than the WHO in a statement in 22 September 2021, when they said and they called on us, on everyone, that we must do much better in terms of gender equality. And yes, that we can do it. Thank you very much.